Thank you.
So Sarah, looks like things have kind of slowed down as far as admitting folks, so we can probably go ahead and get started.
All right, thank you, Dave. Welcome, everyone. And thank you for joining us today for our monthly nursing facility news hour. Introductions, I am Sarah Ogel, the nursing facility program manager. We will also have Dave Alm, our NIF licensing manager, presenting today, as well as Kathy Orias. And we have some special guests today that are going to present. Nirmala Dar, I did see her pop on already, as well as Adrian Butterwick, who's going to give us an update on long-term care behavioral health training for direct care workers. So I just want to give you guys a few updates on where we're at with some statistics. Active executive orders. We are down to 14 nursing facilities, 14 out of our 130 that have actual active cases in them right now. Half of those, 7 of those facilities are for positive staff only. 2 of those have both staff and residents with positive cases, and 5 of those facilities have residents that are positive only. It's exciting to see our numbers have dramatically dropped since December with the introduction of the vaccination. I think that has really had a lot to do with this. And some updates on our actual work. Most of you know CMS sends us a weekly list of facilities to conduct focused infection control surveys. For 2 weeks now, Oregon has had none of facilities on our list needing to do those surveys. And nationally, the numbers are way down. Last week, there was 121 nursing facilities requiring such surveys, and this week we're down to 101. So we are really excited about those numbers continuing to drop. I'm sure folks are interested in where we are with getting back to recertification surveys. We are a bit out from that at this point. Our priorities will continue to be the 3 to 5 day infection control surveys as directed by CMS. Of course, our immediate jeopardy response complaints are one of our highest priorities. And what we're really working on right now are complaint investigations that require a 10-day response. We have a lot of backlog with that. We have some of those surveys that are probably a year or more old that we'll be working our way through. We're prioritizing those with infection control allegations, as well as abuse and quality of care concerns such as pressure ulcers, weight loss, depression, and ADL declines. You may or may not know, we were able to hire 4 surveyors during the pandemic. It was challenging to get them trained and through the federal system to become surveyor minimally qualified staff. And with that, those staff have not had the opportunity to do research surveys. So we are going to start doing some of those surveys with those staff and our trainers. So you will start seeing some of our staff out in facilities doing those recertification surveys. It's going to give them some on-the-job, hands-on experience with recertification surveys. But we will continue to do revisits that are outstanding and work on our 10-day complaints before we get back into recertification surveys. At this point in time, I don't believe any of our colleagues in Region 10 have started recertification surveys, which includes Alaska, Washington, as well as Idaho. There are a few states across the country, we're hearing on Monday calls with CMS Baltimore, that have started to do those research surveys, and we're certainly anxious to get back to them. Our survey interval continues to climb, and we know it's going to be a challenge to get that back in line with our performance standards. And one other thing I want to share before we move on to the next topic is to talk a little bit about breakthrough cases. And these have to do with residents and or staff testing positive surrounding the vaccination process. So we're starting to see some cases that are testing positive before the 14-day post-completion of the vaccine series. And it is believed that those exposures occurred before the immunity of the vaccine has taken place. And these cases are identified either by PCR testing or the antigen testing. And these are still considered positive cases, meaning you need to exclude staff from work and place residents in isolation as you would have previously. OHA is working in collaboration with CDC to identify positive cases that are identified 14 days after that last dose is given, whether it's the second dose for Pfizer or Moderna, or the first dose for Johnson & Johnson, the one dose for Johnson & Johnson. And we want those to be flagged. Please contact local public health, as these meet the definition of a breakthrough infection. They'll be tracking those, like I said, with CDC, and please be sure to alert NIF licensing with those as well, whether it's residents or staff. And I think that's all that I have at this point. We'll encourage you guys to put any questions you have in the chat as we go along today, and we'll do our best to answer those questions. So I'm going to turn it over to Dave, who's going to chat a bit about the new release from CMS last week with the QSO memo on visitation.
Thank you, Sarah, and good morning, everybody. One thing real quick, I've had a few audio issues with my setup, so I'm not going to turn on my camera just to make sure I get a little better connection with you guys. But Sarah or Kathy, if I start sounding like I'm underwater again, just let me know, and I'll switch over to my phone real quick. So as Sarah mentioned, my name's Dave Alm. I'm the Licensing and Corrective Action Manager within the nursing facility team. And you guys, I'm sure, have all seen this by now, but CMS recently released QSO Memo 20-39-NH revised. So basically what they did is they took the QSO memo that was issued in 2020, I think it was September of 2020, and made a pretty significant number of revisions to that memo around visitation. So just a quick little history on this, and everything I'm going to talk about is in the QSO memo. One thing I will say, I'm not going to go through every detail in the QSO memo. I'm primarily going to touch on the changes in the memo. I will point out a couple things in there, but for the most part, these are the changes that CMS made with this last revision. So a little bit of history. You guys have probably seen since the beginning of the pandemic, CMS has issued a few different releases on visitation, information on visitation. There was a memo that came out in March of 2020, which was QSO memo 20-24. They revised their guidance in May, and then they issued a FAQ in June of 2020. This QSO memo and the revisions will essentially replace any information that may have been in those previous memos. So if there's a conflict in information, please use the revised QSO memo 2039. This memo was released originally in September of 2020, and then just revised on March 10th. And again, there were some pretty big changes to it, and we'll just go through those real quick. The other thing I want to mention up front, and I'll mention this again at the end, is there is really no way we can answer every single question around visitation. We have had a lot of specific scenarios that have been sent in to us, and we're trying to help the best we can. But I just want to be really clear. There is no way we're going to be able to answer every single scenario. Every facility is different as far as physical plant structure. Every resident scenario is different, and of course every visitor is going to be slightly different. So there are just way too many variables to be able to address every single situation that comes up. And CMS mentioned this on the call we had with them on Monday. What they're really looking for is that facilities are reasonable and practicable in their approach. So with this guidance in mind, just, there will be some judgment and some assessment and some, interpretation that you guys are going to have to do within your facilities based on your physical plant, the visitor themselves, and of course the residents. The other thing I'll mention right up front is that there is a definition of what fully vaccinated means in this QSO memo. And you're probably familiar with this, but just in case, it means that anyone who has received either if it's a single dose vaccine, they've received the single dose and it's at least 14 days after that single dose. If it's a 2-dose regimen, it would be at least 14 days after the second dose in that 2-dose regimen. The other thing I'll mention too is that the core principles of infection control and prevention have not changed in this memo. All of the guidance that has previously been sent out by CMS and CDC as far as infection control and prevention measures are still in place, and this memo does not change any of that at this point. We are still anticipating at some point CMS will probably issue updated guidance, and I'm assuming the Oregon Health Authority and subsequently DHS will probably be sending out updated guidance at some point. But to this point, there has been no changes as far as PPE use, social distancing, and that kind of stuff. So the primary changes in this memo are around indoor visitation, but I also want to point out that there is still a preference to allow outdoor visitation whenever possible. It's still preferred. And that's whether or not individuals are fully vaccinated or not. So if there is a way to do outdoor visitation, with the weather, or if you have any kind of protection from the weather, that's still preferred over indoor visitation. However, this change really does allow indoor visitation at all times. And there are a couple exceptions that I'll explain in a second. But basically what this memo does is allow indoor visitation. And when it says all times, that essentially is going back to the previous or current regulation, which means that it could be any time of the day or any day of the week. So when they say at all times, it basically is going back to the root regulation from CMS that visitation needs to be allowed or accommodated. So a couple exceptions I mentioned. So you can limit visitation of unvaccinated residents when the county positivity rate is greater than 10%, and less than 70% of residents are fully vaccinated. So then again, this is in the memo, but I'll just say that again really quick. So if greater than 10% positivity rate within the county and less than 70% of the residents in your facility have been vaccinated, indoor visitation should be limited. Additionally, limiting indoor visitation with residents who are confirmed COVID-19, regardless of their vaccination status. And that would be in place until that individual has met the criteria for discontinuation of transmission-based precautions. And then the third is that to limit visitation of residents who are in quarantine, regardless of the vaccination status. And there is a link in the QSO memo to more information on quarantining residents. So I would encourage you guys to go look at that as well. The other major change to this QSO memo is that facilities, or I should say visitors, are now allowed to have close contact, which would include touch if they choose to. It's not obviously required, but if the individual chooses to have close contact, they can now do that with the resident. With a couple things in place. One, the individual has to wear a face mask at all times and has to wash their hands before and after the touch. So those two things still have to be in place. One thing I'll note in this section is that facilities should continue to consider how the number of visitors per resident and how the total number of visitors would affect the ability to maintain the facility's core principles of infection prevention. So this will, this kind of goes into the scenario I mentioned before, where there are lots of variables that go into this. And in a nutshell, the facility does still need to consider how many visitors are or could potentially be accommodated at one time, and the number of visitors at one time. The other thing I'll mention is that it does specifically say that compassionate care visits should be permitted at all times, regardless of vaccination status. So that has not changed. So I think that was all I had to cover in the indoor visitation generally. And then going into the indoor visitation during an outbreak, facilities should discontinue indoor visitation if one or more new residents are identified, residents or staff are identified as being COVID positive. So during your routine testing, if a resident or a staff member becomes positive, you should limit indoor visitation, again, except for compassionate care visits. Then this gets a little trickier, but I'll just kind of go through this. And if you guys have questions about some of this at the end, we'll take a little time to let you ask questions. And if you need more clarification, certainly let us know in this section. But visitation can resume in unaffected areas, so areas within the facility that do not have any COVID positive residents or staff. If the first round testing reveals no additional positive residents or staff in other areas or units. And the second thing is the first round, you can resume indoor visitation if the first round of testing reveals one or more positive case in other areas of the unit, or sorry, if the first round of testing reveals one or more positive cases in other areas or units, the facility must suspend visitation until the facility meets criteria for discontinuing outbreak testing. And I just see a comment that Joy Ramsby pointed out that the QSO letter directs visitors to wear face coverings and masks, which yes, that is true. Under the outbreak testing, CMS did point out that there are no changes to the testing requirements for outbreak testing, so the facility must continue all necessary rounds of outbreak testing until the criteria is met to discontinue outbreak testing. And the facility is still required to notify all visitors of the potential exposure to COVID-19. And again, we're still doing the executive orders when there is a positive case, and facilities will still be required to post the COVID exposure poster that we sent out when we do our executive order. Under the next section of the QSO memo, it talks about compassionate care visits and visits required under the disability rights law. This, again, there really are no changes to this. The visitation should essentially be allowed at all times, regardless of vaccination status. But the one thing it does add is if the resident is fully vaccinated, visitors can choose to have close contact. And again, this mirrors what it talks about with the general visitors. So the other thing I will point out in here that CMS added is that there's a section under our state surveyors. It specifically says that the facility cannot require surveyors to be vaccinated and must permit entry to the facility unless the surveyor has signs or symptoms of COVID. So this question has come up a couple times around vaccinations and surveyors. So just to restate that, facilities cannot require surveyors to be vaccinated and must immediately allow them in the building unless they have active signs or symptoms of COVID. And then I'm just going to, a couple closing things I'll talk about, and then we'll open it up for questions. Just wanted to remind you that per the federal regulations, facilities can't restrict visitation without a reasonable clinical or safety cause, which is outlined in the CFRs. It's 483.10. But the reason I bring that up is because this has always been in place. So if there is a reasonable clinical or safety cause, the CFRs do allow facilities to restrict visitation. But this is not necessarily directed specifically at COVID. Again, this was one of the existing requirements. And then I just want to restate what I kind of said at the beginning. There really is no way we're going to be able to answer every single scenario or question or specific scenarios or questions around visitors. So just to remind you that you guys should be using your judgment and taking a reasonable and practical approach to visitation. So that's all I have. I will, real quick, before I open it up for questions, I'm going to open it up to anyone from the nursing facility team to see if I have by chance missed anything or if there are any comments anyone would like to add.
Dave, this is Jeremiah. I just wanted to touch on, you talked a little bit about facilities limiting the number of visitors in the facility at one time. And it also, in that same paragraph, talks about, if necessary, facilities should consider scheduling visits for a specified length of time to help ensure all residents are able to receive visitors, and then they have time to disinfect and clean the visitation area. That was the only thing that I wanted to bring up.
Thank you, Jay. All right, I'm going to take a quick look through the questions that are in the chat. While I'm doing that, if you want to ask questions verbally, you can unmute yourself. If you happen to be on your phone, I muted everybody at the beginning, so you may have to press *6 to unmute yourself. And then we'll just take a few minutes here to answer questions, and then we'll move on. So one question that came up is, do visitors need to wear eye protection or just a procedure mask? Our understanding, and Joy or Lori, please feel free to jump in if you have any additional details to add, is that the OHA CDC requires a face mask, but it does not require visitors to wear face shields. I know some facilities have policies and procedures that are a little stricter, but if a visitor does not wear a face shield, that doesn't mean you can restrict visitation. What's really required is that they wear a face mask, and of course, hand sanitation.
Dave, this is Lori, and that does make sense. I was thinking we could run that by OHA just to make sure that we are providing consistent guidance.
So thank you, Lori. Yes, we have actually run this by them a couple times, specifically for visitors. Actually, this question has come up for both visitors and contracted staff, like outdoor or vendors, facility vendors, and that was the answer that we have been able to get from OHA. So I think unless something has changed recently, that's kind of where we're at least at this point in time.
Great, thank you, Dave.
Yeah, of course. Question about should we continue to use barriers for inside visitation, 6 feet social distancing, except when touch being done. So yes, as I mentioned in this section, the core principles of infection control have not changed. So when at all possible, facilities should still, or visitors should adhere to the 6 foot social distancing. Facilities, if possible, use the barriers. It's always a good idea. And again, as it kind of said in the question, except when there is individual personal touch. And I think that's my understanding as well. And again, Lori or Joy, if you guys have anything to add, or anyone else from the NIF team, let me know.
I will say that the QSO letter is now really focusing on a return to that person-centered and privacy during visits. And so I think you need to think about that when you're using barriers. It also really speaks to the barrier as being that additional protection for both the resident and visitor. It comes off sounding more as a recommendation and a best practice. So I think those are all things you need to consider.
Thank you, Joy. Next question was, are entertainers allowed back in the building for life enrichment activities? That's a good question. We may want to take this back and have a little further discussion. I know activities can, somewhat resume. My initial thought is, as long as there is appropriate infection control prevention measures in place, it's well, actually, maybe I shouldn't say that, but we'll take this question back just to make sure that there isn't anything we're not thinking of from OHA's perspective. And the reason I kind of hesitated, because with performers, particularly if they're singing, it could, there's more air coming out. So there may be some slight differences as far as social distancing and other things, but we'll take this back, and then we can get you guys a follow-up answer. So next question was, if the guidance we received from OHA or DHS contradicts what's in this QSO memo, should we now be following the QSO memo? And the simple answer is yes. We are trying really hard, specifically for the nursing facility program, to go with what CMS and CDC is publishing, or what they have sort of approved, so to speak, for nursing homes. There are a few things that OHA has recommended, which would be in addition to potentially what guidance has been sent out by CMS. And certainly those recommendations, particularly if there's an outbreak, should be followed. But again, for the most part, we're really trying to be consistent with what CMS has published. And we are in conversations with OHA just to make sure that anything we send out, they're at least aware of, so that we don't have conflicting information. There was a case recently, I think it was a couple weeks ago, where some information from OHA came out that was more geared towards community, and it was a little confusing in the guidance. So we did check in with OHA on that, and I think they have since clarified, because and I can't remember specifically what that guidance was, but it was in conflict with what CMS had released. So if you see those, certainly let us know. We don't want major conflicts to be out there, and we would certainly like to address them, but hopefully for the most part, we're consistent. Another question is, we have all private rooms. Any issues if all these visits are just held in resident rooms, so we don't have to schedule visitor times? This is kind of getting into one of those specifics that without all of the information, it's a little bit hard to specifically answer it. I think anytime a resident is in a private room, it's definitely going to make it easier for you guys to schedule visitation, because you're not going to have to worry as much about roommates and social distancing and all that stuff. It certainly, Matt, if you want to reach out to the policy analysts and maybe talk in more detail, we can do that. But again, this kind of goes along with what CMS has told us and what we're kind of relaying to you guys to, use some of your judgment when you're coming up with some of these decisions, and do what you can. And certainly if you want to run it past us, you can. We may or may not be able to answer some of the specific questions, but we'll certainly try. And in case you guys can't see chat, there was a question about updating guidance for assisted living and residential care facilities, and Sarah pointed out that that's in process.
Hi, Anna. Yeah.
If you guys could make sure you're muted, that would be good. We're hearing some background noise. I'll take one more question right now, and then we'll move on. Otherwise, we'll give you some time at the end too, if you think of any other questions. So how closely do we need to monitor in-room visits? Unsure of how we would ensure social distancing, masks, hand hygiene, that kind of stuff. This question has come up several times, and honestly, I think it really depends on the visitor, the resident, and how comfortable you guys are. You're going to know those visitors much better than we would. Some visitors would, follow everything to a T. Others may not, or you may know that going into it, that there may be concerns about them not following infection control. So your approach is going to differ slightly, potentially based on the visitor or the resident. So I think you guys will probably need to look at that on an individual basis and make a decision. So. All right, so there are a couple more questions coming in, and like I said, we can come back to those, but let's move on to the next topic, which is, sorry, real quick. If you can go back one slide, Kathy, sorry, I forgot to mention this slide. Forward one more. CMS did send out it's a document called When Can I Visit Her Nursing Home? And it's a little summary sheet of the new guidance that came out. So you guys are welcome to post that. I think it's actually a really good little one-page summary of what happened, what changes, and what to do. I believe Kathy sent that out in the provider alert we sent yesterday. So there should be an attachment in that for you if you don't have that.
Dave, excuse
and then
me,
Kathy,
I lost the slideshow. Do you see it?
Nope, it did go away. You may have to pull it up again and then if you have issues, Kathy, I can pull up from where you left off.
It just seems odd that just happened. Sorry, everybody.
Yeah, and you might need to stop sharing real quick. It looks like, oh, there it goes. It's back.
Are we good?
Yep, looks like we're good. Thank you. So Kathy, I think you're up.
Hi. Now I only have the view of the slideshow, so if any questions pop up, we can deal with those at the end. I just wanted to touch base with everybody about the CMP reimbursement opportunities for the communication technology reimbursables should be completely done. I have 15 facilities still outstanding with receipts that have not been submitted. So if your facility has not been paid for your iPads and tablets to facilitate, virtual visits, please reach out to me. I did have a few facilities who did not apply, so those 15 is only relating to the ones that are outstanding and applied. It's not too late to apply if you need to purchase those items, qualified devices for facilitating virtual visits. Please feel free to reach out or submit an application. On our nursing facility website, we have the link for the indoor visitation applications. That's the new initiative for CMP reimbursements. So what that is, and I've talked about it several months in a row, it's for tents and structures, plexiglass, items that are qualified as listed on the FAQ and the application, but items that help facilitate outdoor visitation that, for example, maybe it's a tent that's a gazebo and you have it professionally installed. CMS is facilitating payment for the professional installation as well. So that's up to $3,000 per facility. I have a few corporations that have applied, but not as many. Now that the weather is changing and things are opening up, I feel that this is a great opportunity for facilities that may need to purchase items that help with the outdoor visitation. Please, submit your receipts at the same time if possible, and then I can get your approval at the same time as the reimbursement to sort of cut down on how long it takes. The communication technology reimbursables took a great deal of time, and I really appreciate everybody's patience with that process. But we did learn a lot during that, and so having the receipts along with the application, providing they are qualified items, will really help speed things along. Another thing that will help speed the processing up is if you include your tax ID number with the receipts. The way it worked previously is I was looking those up, and it would be helpful if you just provided that at the same time. That's something I had not instructed anybody to do because I didn't realize we needed it. So those are some lessons learned moving forward on the indoor visitation applications. And the next slide does, providing this offers a link to the application and FAQ. And then I just want to remind everybody that this slideshow, this recording, and our agenda all have links and will be posted on our communication page. So you can go back, listen to it, and link up to even mom's vaccination flyer had a link there. So it's a little bit more interactive if you need to visit this later for more reference. And there'll probably be some questions. Feel free to email me. My email's at the bottom of this slide, or our NF licensing box, and I'm happy to answer any specifics. I know that we have guests today who are anxious to share, and this is one of the projects that are actually sponsored by our CMP funds. So I will turn it back over to, we have Nirmala Dar from OHA, and we have Adrian Butterwick from Co-Imagine Health. Not sure who's going to take the ball, but welcome to the News Hour, and please feel free to take it from there, Nirmala or Adrian.
Hi, thank you so much, Kathy. I do have a PowerPoint presentation. So am I able to share my screen?
I believe you are.
Okie dokie. It says I have.
Let me stop sharing.
And it is waiting for approval here.
I have. Uh-oh.
Just says it's waiting for approval to allow me to share.
Okay, Adrian, I'm ready too, so.
Okay,
I think I'm technically challenged here, folks.
no problems at all. Teams is not the most user-friendly platform in my opinion, so I definitely have my own issues as well.
Oh, here. I have it. I see it. Sorry. Try that again.
Okay.
And I'll approve it. I'm so sorry to interrupt you speaking.
Oh, it is not a problem at all. Let me see. It's not letting me request now. Well, I think we can go ahead and just go through our presentation and discussion, and I'll just share the slides with you to review afterwards. I really don't want to take a lot of time away from everyone's busy schedules today with some of these issues here. If that's all right with you, we can just go ahead. So as you mentioned, yes, thank you. My name is Adrienne Butterwick. I am an improvement advisor with Comagine Health. We're the state quality improvement organization. We work in a regional fashion, so we oversee Oregon, Washington, Idaho, New Mexico, Utah, Nevada, and then we do have some other projects that I am the state lead for quality improvement for Utah, but I also work with facilities in Oregon, Wyoming, and Montana. So I am just really grateful to be here. Thank you so much for giving me a little bit of your time. We are here, Nirmala, and I are here to discuss the virtual training series that Kathy just showed the flyer for. And I want to make sure to give Nirmala a chance to kind of introduce the background. She's been instrumental in getting this project, approved and going forward. So I just want to make sure that she has a chance to share with us some of the background and intentions. Nirmala, do you want to go ahead?
Yes, thank you, Adrienne, and Kathy, Dave, and Sarah for giving us this opportunity to present today. I'm absolutely thrilled to be here today to really kind of let you know about our behavioral health virtual training series. I just want to throw out a mystery number first, 500,000. And what is this mystery number? On any given day, in our nursing homes across the United States, there are 500,000 or 500,000 people in nursing facilities with a serious mental illness. And this excludes dementia. This greatly exceeds the number in all other healthcare institutions, including psychiatric state hospitals. And very often, mental illness is sometimes the one and only decisive factor contributing to placement in a nursing home. So again, I want to emphasize 500,000 people on any given day residing in nursing facilities have a mental illness. And here's some data from Oregon. It is a little dated 3 years ago, but still very relevant. It was taken from your MDS mental health data. Between depression and anxiety, which are mental health diagnoses, there were close to 48% of your residents had that. And serious mental illness, which means schizophrenia and a bipolar disorder, close to 6%. And then there's a study done every year by Portland State University Institute of Aging. Their latest report is still to be published, but the 2018 report indicated that when you combine depression, anxiety, and schizophrenia and bipolar disorder, about 42% of nursing home residents have these very serious mental illness diagnoses. And I haven't even thrown in numbers for substance use disorder. Suffices to say the need is great. There is a great need for training frontline staff in what are these mental illnesses, how do you recognize it, and what are some best practices that any one of you, including frontline CNAs, can employ in working with individuals with these serious mental health issues to improve their quality of life. And with that background, that was really the catalyst for creating this, I think, very user-friendly, packed with a practical tip, virtual trainings. So thank you again for letting me speak. And Adrienne, I'm going to pass it back to you.
Thank you so much. So as normally said, this is a very important topic, and we are just really excited to bring this training to all of you and your staff and your facilities. The program was developed with the Oregon Department of Human Services and the Oregon Health Authority, and it is supported by the CMP funding, as Kathy mentioned earlier. It's delivered via interactive web-based modules. The training includes the latest information and best practices for long-term care providers and encompasses 4 topics, as you can see listed on the screen there. Each section includes a pre and a post test and a certificate of completion. The training also includes PowerPoint presentations, handouts, and other resources that allow for individuals themselves to access on demand, or facilities can actually conduct these trainings in large group settings. And that's kind of what we're hoping to accomplish here is not adding anything to someone's plate, but really just finding ways that you're already providing education for your staff and plugging this into the system and programs that you already operate. So we are hoping that because it is virtual and it is on demand, that it is flexible to meet your needs, and we are working with facilities to get these trainings incorporated. So that's why we're here today, is just hoping that you would be interested in also taking us up on that. I will, in the PowerPoint slides that I'll share to Kathy and Dave to share with the group here, there is a screenshot that just shows you the homepage for the learning management system and where you would click to find the long-term care behavioral health trainings. And as I said, we're rolling this out to collect participant feedback, make any changes needed to the program. It was kind of in a pilot sentiment, if you will, just trying to collect feedback and make sure the program is the best it can be. But we're also looking to potentially assess the impact of the training on any quality outcomes for facilities that are also conducting the training. So we're kind of hoping to look at the impact and make sure that we're meeting the needs and making making a good impact on quality outcomes. Because this training was developed with the CMP funds, we're rolling this out to your long-term care groups first. But we may this may be expanded to other settings in the coming months. But we just want to be sure that that you all are the ones who can reap the primary benefits here from the training, because it is funded by your programs. So you probably saw the provider alert back on February 24th. So we really appreciate the partnership to help get the word out. We saw a big increase. We saw about 50% increase in registrations and participation after that. So we really appreciate some of you and acknowledge that you may have already seen it and gotten a little bit involved. So thank you to those who are already moving. And that is really the short and sweet presentation for today. I'm happy to do a live demonstration or walk through the modules if anyone is interested in taking a look before kind of rolling it out or bringing it back to your training, whoever oversees the training in your facility. And then you can also just reach out to me with any questions that you have about the training or anything at all. My contact information is on that flyer, and it'll also be in those slides that I share. So I don't know if there are really any burning questions about that, but I'm happy to take any questions that you have, or we can go ahead and move on. I know we've got a pretty packed agenda for today.
Adrian, this is Nirmala. I just want to add that in the transmittal letter that went out to all nursing facilities, we gave my name as a contact in case you would like this to be provided as a live interactive training for your staff. If you think that would be of interest to you, please refer to the letter of transmittal, and this is Nirmala. My contact information is on that letter, and I'm very happy to coordinate to see how we can present it as a training, live interactive training, using the same materials in one of your staff meetings or some other venue. Thank you.
Thank you so much, Nirmala. I apologize for not mentioning that explicitly, but I do appreciate that that you're just such a fabulous partner. So thank you so much. And thank you all for your time today. I really appreciate being able to be here with you.
Thank you both very much. We really appreciate the overview. And I personally am very proud to be a partner with you on this too. DHS and CMP funds made this happen. So happy to see this. Thank you. Dave, I'll let you take it.
Thanks, you guys. So I'm going to real quick here put in the chat. If you guys do need to ask a question and you're on mute on your phone, just press the *6 and it should unmute you, because I think at the beginning I muted everybody. So if you're on your computer, you should just be able to click unmute. So we'll see if there are any more questions. First, I will ask if anyone has any verbal questions and give you just a second to reply. And this would be about anything we've talked about today. Okay, and then there looked like we still had just a couple follow-up questions around visitation in the chat. So we can go through those real quick. And then again, we'll just give you another few minutes to ask any questions, or if you're working on a question in the chat, you'll have a little bit of time. So one question was, are there any updates to staff members wearing face shields, eye protection, in addition to surgical masks? Not yet. We have had some recent conversations with OHA, Oregon Health Authority, about this, and to date, there are no changes. However, I know that that is in the works. So we are actively in conversations with OHA around that specific topic. And I do, so thank you, Nicole, for your comment around the memo, because I was trying to think back to what I told you guys versus what I was saying in my head. And I do want to make sure it's really clear that for the touch component of the indoor visitation, that is for residents who are fully vaccinated. So I just want to make sure I did state that very clearly, because I may have either gone over that really quickly or forgotten to mention that part. So I apologize. That is specifically for residents who have been fully vaccinated. And then for your second part of the question, what is the expectation if unvaccinated resident families are hugging and touching? And this, I think, will require some upfront education. I think, facilities are going to have to do a little work before the visitation happens to make sure they understand what the status of the resident is and what they can or can't do. And kind of going back to what I said before, each visitor, each resident is going to be slightly different. So using your best judgment as far as what type of monitoring or oversight you may need to do. If they are fully unvaccinated and you hear that there is direct touching, certainly the consequences need to be explained, or the potential risk needs to be explained. And, I think if it continues, you can certainly put them on notice that it's not allowed at this point anyway. So, and may be able to have to limit visitation, or maybe do more controlled visitation where you can have some oversight by the facility staff. So I'll give you guys just another couple seconds here to send anything in by chat, or again, if you want to ask a question, you can unmute your phone or unmute your computer. Phone would be *6 to unmute. So is there Oregon guidance on communal dining and activities, or do we follow the CMS QSO memo? And at this point, we follow everything that we have sent out so far is essentially based on what has been coming from CMS. And again, we're trying to be as consistent as possible. So yes, follow the CMS guidance on both communal dining and activities. We are working on some future policies and procedures around, what happens now that individuals are vaccinated, but I don't expect we're going to send anything specifically for nursing facilities until we hear more information from CMS. All right, I'll give anyone from the nursing facility team, or do you guys have any other comments or anything to add?
Not from me.
All right. So, and Sarah, I think we'll turn it back over to you for closing.
All right. Thank you, everybody, for joining us today. It's always good to have these meetings. And prior to the pandemic, we were doing these quarterly, but when the pandemic started, we started scheduling them monthly. And at this point in time, we're going to continue to have those scheduled monthly just because we anticipate continued ongoing changes as we move forward, hopefully getting to post-pandemic, and suspect things with vaccines may come up. As they research and look at variants, could have some impact. So like I said, we're going to continue to schedule these monthly. Come summertime, sometimes that's challenging to have folks join us, and we'll only cancel them should there be issues out of our control. And again, we would encourage you guys to let us know topics that you're interested in so we can prepare for those. But other than that, we will see you all again on April 15th, Tax Day, although I think I heard that might have been postponed a month. So anyway, it's always glad to have you guys join us, and we look forward to seeing you again in a month. Thank you.
Kathy, real quick, I just want to ask, you're going to post the recording, correct, on the website?
Yes.
Okay, perfect. Thank you, everybody.
Thank you.
Thank you.